journey there. So here we are handovering the medal, citation and memento to Dr. Sahay sir, as a form of appreciation and respect. Thank you so much, sir. Thank you. And the information results of the postal and order presentation will be announced in joyfully report at 1:30 p.m. during the valedictory function. Over to you, Doctor.
So good afternoon to all of you, and at the outset I would like to thank Dr. Jyotidev for inviting me and giving me this honor. So I'll be in the 15 minutes time that is allotted to me, I'll be covering two aspects. One is about this new treatment option in the management of diabetic foot ulcer, which is an Indian innovation, and then I will also speak about some of the data from the RSSDI Save the Feet campaign which was done. So what we found about the diabetic foot in our prevalence of diabetic foot in our country and its correlation with the other complications of diabetes. So these are the two things that I'll be covering in the next 15 minutes or so. So diabetic foot ulcer is a very common complication of very important complication of diabetes, we should say, and it's associated with a very high risk of lower limb amputations and mortality. And it's one of the most distressing complication, you could say. It's a complication which is causes huge impact in terms of economic burden and in terms of loss of you can say dailies in terms of quality of life affected and all that. And if you look at the most common type of foot ulcers that we have in our country, we have more of neuropathic ulcers being very common as compared to some other parts of the world where we have more of ischemic ulcers. We tend to have more of neuropathic ulcers in our patients. And if you look at the global prevalence of some of the statistics in terms of the global prevalence, we can say that there are almost about 20 to 26 million people developing foot ulcers every year globally, and almost 6% of all diabetic patients. The incidence wise, maybe about 6% of diabetic patients, and this is how you can see the distribution in type 1 and type 2. Maybe type 2 is slightly more common in type 2 than in type 1. That is what is shown globally, and they are more common in men than women because they tend to go with into work barefoot, and those are common factors which are contributing to foot ulcers. Lifelong, if you look at the entire life burden of diabetes, along the lifespan of a person with diabetes, we could say that 1/3 of people with diabetes at some time or other develop a foot ulcer, and it becomes a major cause of non-traumatic limb amputations, and it's estimated that every 30 seconds somewhere in the world one patient is undergoing amputation for a foot ulcer, and 85% of these amputations are preceded in patients with diabetes are preceded by foot ulcer. So they start off with the ulcer, not well managed, they end up with amputation. So it's very important that we prevent the foot ulcer itself and then manage it effectively if it develops, and prevent the amputations. And it is most costly complication of diabetes, one of the most devastating complications of diabetes, and approximately 20% of all hospital admissions are because of occurring in people with diabetes are because of foot ulcers. And you can say that almost it has got if you look at the morbidity and mortality, it's quite severe. About 5-year mortality with diabetic foot ulcers is about 46.2%, and once a person develops amputation, the 5-year mortality becomes more than what is seen with most of the cancers. So that makes it a very distressing complication. It's a problem that needs very great attention, and we should focus our attention towards that. So having looked at that, let us look at some of the factors that predispose to the development of complications. It is ischemia, neuropathy, and infection, which together actually lead to the ulcer, and because of the poor glycemic control, that adds on to this, the healing becomes slower, and that complicates multiplies the whole problem. So if we briefly look at the pathophysiology, we could say that because of the high glucose levels, the activation of aldose reductase pathway, the sorbitol pathway leads to accumulation of various products which are leading to increased reactive oxygen species, peripheral neuropathy getting aggravated, peripheral arterial disease getting aggravated, and infections adding on to this. So this is what the common pathophysiological factors are playing a role. I will not go into details of that, but we have different classification systems. We go by the Wagner system, which is quite simple to use, but a more stratified classification like the University of Texas classification adds on, gives importance to infection, ischemia, and the presence of either of these, and they are given separate categories, and you can use this for prognosticating the wound. So having looked at that, it is very important to differentiate neuropathic from neuroischemic ulcers, and the simple test like looking at the ABI value itself that can help us in differentiating, because lower ABI or very high ABI indicates ischemia versus calcification, vessel hardening, and that's a very common modality that has to be used. And we have the standard treatment has been based on analgesics, antibiotics, debridement, and wound dressings. But we are on the lookout for better therapies and better treatment options, and towards this end we have a new molecule called the esmolol hydrochloride gel, which has been introduced it's a repurposed drug which is being used, as we all know, it's a beta blocker, and it's used intravenously for various cardiac conditions, but here it is repurposed for use as a foot ulcers as a topical gel, and requires local action at the wound site with minimal systemic absorption. So we have a preparation that provides this pathway. And how does it work? It works by inhibiting the polyol pathway. As we said, that it's an important pathway which is leading to the aggravation of the neuropathy, and it also it inhibits the polyol pathway and reduces oxygen free radical generation. In addition to that, it has other actions like it promotes the migration of three key cell types into the wound healing area. That is human fibroblasts, endothelial cells, and keratinocytes, and also induces endogenous nitric oxide production, which has got vasodilatory properties, which improves the wound healing. So these are the three mechanisms by which it's working. Now let me quickly show you some clinical evidence which is there with the use of this new drug, which has been repurposed for treatment of diabetic foot ulcers. This is a phase 3 randomized trial which is conducted across different centers in our country. They looked at 251 ulcers were screened, and out of this 163 individuals with foot ulcers were randomized to either the new preparation, that is topical esmolol plus standard of care, or just the standard of care, and a placebo plus standard of care, placebo gel which was used to provide a similar sort of feel to the patients. And this was followed up for 12 weeks, and then another further follow-up for 12 weeks was done to look at the wound healing. And the primary endpoint that was looked at, so the inclusion and exclusion criteria listed here, basically patients with a neuropathic ulcer identified by monofilament testing, grade A1 full thickness ulcer with the area between 2 to 15 centimeters was taken, and the exclusions were particularly looking at infection, gangrene, or ischemia, excluding those, and the primary endpoint was the wound closure occurring within 12 weeks of the treatment. And secondary endpoints were looking at 24 weeks what was happening to the proportion of wound closure, and also looking at the effect of this treatment at different sizes of ulcers, and also at different HbA1c levels and at different API levels. So the primary endpoint was seen to be amongst the treatment group. It was achieved in 60% of the patients as compared to 41% of the patients in the standard of care group. So clearly showing that this was better than the standard of care. And the other secondary endpoints that we looked at were also significantly better in the treatment arm as compared to the standard of care arm. As you can see here, 77% had closure at the end of study, that is week 24. At week 12 also you found that a higher number of patients reached their target, had closure of the wound. At 24 weeks, as you could see that the number went up from 70 to 77%. And the mean time of, although if you look at the mean time, there was a slight reduction in the mean time, mean time to ulcer closure, but no significant change in terms of that. And follow-up assessments also showed that this molecule was better in terms of reduction in the area of the wound and the reduction in ulcer area, and also in terms of the location of wound and wound size. It showed that both wounds, that is plantar versus non-plantar wounds, and those which are small or large, they fared better with this new molecule. So I think all these results want to show that this molecule holds promise in the treatment of diabetic foot ulcers, and it had there was a robust safety profile without any significant adverse events being reported with this. So this has also been, other studies have also been there from across the world which have looked at this molecule and have shown that there are promising results from this molecule in the treatment of diabetic foot ulcers. So I think this molecule therefore provides gives us a sort of hope that there is probably a good molecule which will help us in getting a better ulcer healing with the use of this topical preparation of espuroline. So having looked at that, now in the last 4 minutes that I have, what I'll try to do is I'll try to show you some data from a practical campaign that was carried out 2 years back across the country, and we recently published this also. So this was early screening for foot problems in people with diabetes, and I'm sure many of you would have participated in this campaign, which is called the Save the Feet campaign and Keep Walking. And this was carried out by the Diabetic Foot Study Group of RSSDI under Dr. J. Vishwanathan. So this was basically to look at the burden of foot problems in our country and determine the burden of high-risk feet, those with loss of protective sensation among people with type 2 diabetes, and to look at the distribution of neuropathy versus ischemic ulcers in our population. So this was carried out within a 2-month period. Over 10,000 doctors from the membership of RSDA participated in this campaign, and there was a 3-minute study to prepare 3-minute foot examination guideline which was prepared. Module which was prepared and which was popularized amongst all the doctors, and using an online survey form, people participated in this, and total of 54,000 people, patients with diabetes above the age of 18 were enrolled in the study, and out of this 33,000 were included in the final analysis after excluding those where incomplete information was there. So based on the International Working Group definition of diabetes foot, the classification was made into different risk categories: very low risk, moderate risk, or high risk candidate, and data analysis was done. So as you can see that if you look at on the right side, you see that if you look at the status of HbA1c across our country amongst these 35,000 patients, we see that only about 20% of patients are achieving a target of less than 7%, which is true in our clinical, which we see in our clinical practice, and showing that we need to do more in terms of getting more of our patients at the target. 12.8% patients were smoking. And if you look at the previous history of foot problem, almost 20% of them had previous history of foot ulcers, lower limb amputations in 15%, and almost 14% had some degree of vascular intervention also. Renal complications were present in 17%, 28% had eye complications, showing that quite a good coexistence of all the other complications of diabetes which need to be screened for when you're looking for people coming with diabetic foot ulcers. And if you can see the distribution of these patients in terms of the risk of the foot, risk categorization of the feet, we see that almost 30%, 25% had were in the high risk group, 22.5% in the moderate risk, 5% low risk, so what we see is that almost about 30% of patients had significant problems in their feet, and this underscores the importance of screening of all our patients for foot problems, and identifying and also looking for at the same time doing a renal screening and also looking for renal involvement also. So if you look at the statewide distribution of these problems, we see that in Kerala you can see that 18% had very high risk feet, and 1.2% moderate risk, low risk was 1.7. So showing that almost in Kerala also about 20% of the patients had a significant problem in their feet. So we have several such programs coming up with RSSDI. RSSDI is taking up an India-Med study, which is going to be a community-based study looking at metabolic profiling of rural Indian populations. We're collaborating with the Vitreoretinal Society of India to carry out a campaign for screening for diabetic retinopathy. We are looking at screening for MASLD amongst, involving all the members of the membership of the RSSDI across the country, and a phase 2 of the Save the Feet campaign as was carried out earlier. So several digital initiatives are also being taken up under the RSSDI Koita Center for Digital Diabetes, which is being set up, and I urge all of you to participate in this, because what we look at is teamwork, which sees that we all achieve more, and we brings out the creativity, partnership, development, solution, and communication, improves the communication. Thank you all for the patient care. Thank you once again to today for inviting me.
Thank you, Dr. Rakesh, for making a concise version of that foot, which is a very complicated thing. Rakesh, the only thing I would like to make, when do you start using the esmolol in a ulcer? In the sense, before the infection is controlled, or when in the stage should you start?
Yeah, I think it is started after the infection is controlled, then it gives the best results.
Is it available commercially?
Pardon me?
No, is it available commercially?
No, I don't think it's yet available commercially. It will be launched soon, I suppose. Yeah, I was just showing that in one of the slides where we said that it has different. It increases nitric oxide release, local nitric oxide release, reduces the activity of the polyol pathway, and also has other molecular effects which increases the recruitment of the macrophages and all that. So through all these mechanisms, it is causing an improvement in the vascularity, local wound healing is improved. So that is how it is working. Yeah. So this has little different qualities in the sense that esmolol is one of those beta blockers which increases the nitric oxide levels. Locally also it increases the nitric oxide levels, and is IV preparation that is used esmolol. So it is a short-acting beta blocker which has got some vasodilatory effect also with nitric oxide production being increased. So that property is being used here in terms of the body.
We will wind up the session. It's an oration and
donates nitric oxide. So is Nebulon better than?
Well, I don't think we have that preparation, the hydrogel of which was made for this. Maybe that could be another thing that could be studied, because nebivolol is also known to have that nitric oxide increasing property when it's used orally. So yeah, it's a longer duration, may have a better action, but that's something which further needs to be studied. Yeah.
we will wind up the session.
even though it's an occasion.
Yeah.
We'll wind up the session.
Thank you.
Thank you.
Thank you. Thank you.
Thank you so much, chairs and speakers, for the excellent session. Going to the last session, that is driving ahead, managing diabetes for safe and confident travels. To chair the session, I would like to invite Dr. Harikrishnan R, consultant physician and diabetologist, Professor of Medicine and Hematology, Government Medical College, Trivandrum. Also, there is an information we will be having the valedictory function at 1:30 p.m. Thank you.